Welcome to the ultrasound world for a better diagnosis and treatment. What is Shiva? It's a mental attitude. My mission is to build on the knowledge I have acquired over 25 years of working alongside Claude Franceschi, great friend and teacher. Welcome. In the 19th, the presence of extracephalous refluxes was known, but their origin was unknown. Many angiologists were also unfamiliar with the concept of veno-venous shunt. Claude Franceschi, on the other hand, knew that if a shunt exists, there must be an escape point to feed it. Following Valsalva's historic refluxes, where the origin wasn't junctional or from perforators, thanks to his experience in ecoduplex examination, he discovered a possible origin from perineum or the inguinal areas. Rechecking anatomy, he realized that vein passing through the pelvic wall had been described by anatomists. He therefore realized that, at those points, valve incompetence could create retrograde flows in the opposite direction to the physiological one. Welcome. The impact of pelvic escape points is significant. PLPs represent the escape point of shunt A4 and 5 according to the Shiva shunts classification. This study shows that echo-guided minimally invasive surgery of refluxing pelvic leaks is reliable and durable, and above all, that pelvic varicose embolization prior to PLP reflux ablation is not necessary. Misunderstood PLP's existence cause a relapse of varicose vein, especially chaotic in case of ablation of the great saphenous vein. The association with the pelvic congestion syndrome is rare, but it's possible, and so we must look for it. The Valsalva maneuver is mandatory to detect a systolic reflux of pelvic origin at the PLP level. Here you are an example of the effect of knowledge on strategy. 32 years old woman, 4 pregnancies, varicose veins of pelvic origin. No pelvic congestion syndrome. A Shiva strategy was planned, and the tactic was surgery. First step: eye points disconnection and double disconnection along N2 in the right eye and N2 and 3 on the right leg. 5 months later, PLP's disconnection. Welcome to the ultrasound. You can see the right lower limb before and immediately after the second surgical step, without destroying any great saphenous vein segment, and above all, without any need for pelvic endovascular embolization. Welcome. Therefore, varicose veins of the lower limbs caused by pelvic reflux are a reality to consider. Knowledge of the anatomy of the abdominal wall, as well as perineum and pelvic venous unit, indicates the possible anatomical points through which a pelvic reflux can reach the lower limbs, as well as the reasons for this reversal flow. The pelvic venous network is composed of several interconnected avalvulated venous plexuses, as if it were a single venous sponge. The plexuses drain predominantly into intermediate parietal and visceral largely valved collectors, which flow into the large iliac mainly avalvulated collectors, into the renal veins or directly into the cava. Beware, plexuses may also drain directly into the hypogastric vein. The pelvic venous unit is a venous system functionally integrated with the inferior and superior cava systems to always ensure flow to the right heart. An example of organization into multiple venous pathways to always allow the cardiac preload and tissue drainage, both in pathological conditions such as stenosis or occlusion, as well as particularly during pregnancy. For this reason, other collectors must also be considered when studying the pelvic venous drainage structure. Of particular interest are the posterior internal parietal and perivertebral drainage system connecting with the azygos and hemiazygos systems. The pelvic venous unit is organized according to precise functional requirements. a central valveless area of plexuses and valveless uterine veins provide perfect flow distribution in every direction. Outside it, there is a second functional area of valved parietal and visceral collectors to ensure the flow direction to the heart. If hydrostatic or residual pressure were to increase, open vicarious shunt or refluxes through the PLPs would be activated. Welcome to the ultrasound. The iliolumbar is an important vein. It has valves and originates from the muscle behind the psoas and also from the psoas muscle. It is the origin of the possible posterior open vicarious intercabal shunt. It receives vertebral branches and may be joined by a branch to the deep circumflex iliac vein. Different patterns of confluence exist, a single common trunk or double left and right. Usually, it joins the common iliac vein, but in 15% of cases it can reach the external iliac vein or even the hypogastric vein. It continues upward with the ascending lumbar vein. It has relations with the lateral sacral veins and anterior sacral plexus. Welcome. Ovarian veins, azygos on the right, hemiazygos on the left, sacral and anterior vertebral plexuses, lumbar veins, iliolumbar veins, ascending lumbar veins are part of an alternative drainage path interconnecting the inferior and superior cava veins. The iliolumbar vein represents the posterior origin of this emergency venous path. The anterior vertebral plexus and lumbar veins are also widely interconnected. Welcome. Ovarian veins may have an ostial valve on the right, rarely on the left. The presence of ostial valve is reported in 50% of cases considering both sides. The confluence of the ovarian vein may occur on the left in the vena cava, in a lumbar or adrenal vein. On the right, the confluence of the gonadal vein is also described in the renal vein, 10% in male, 7% in female, or directly into the azygos. Renal veins can be directly interconnected with lumbar veins, a further venous path joining the azygos and hemiazygos system. The renal azygos lumbar venous path can be activated in case of increased transmural pressure in the pelvic venous unit. An example is in the complete nutcracker syndrome. Top right, you can observe a clear bimode demonstration of the existence of this venous path. Welcome to the ultrasound world. The green line represents the lower and upper gluteal veins. The dot green line is the vein segment above the piriform muscle. They flow via common trunk into the hypogastric vein. They enter the dye, surrounding the sciatic nerve, by forming a plexus of small echoductless detectable veins up to the lower third of the dye, pink curved line. Let's go into detail about the connection with the deep femoral vein. The inferior gluteal vein in its tract outside the pelvis, between the quadratus femoris muscle and the adductor minor in depth, and the gluteus major, joins with the deep branch of the medial circumflex femoral vein and the first perforating vein of the thigh, tributaries of the deep femoral vein. The hypogastric vein, therefore, joins the common femoral vein. This is a possible compensation shunt between the two vessels. The venous plexus of the sciatic nerve is a group of small echo-visible veins that surround the nerve, a residual of the sciatic vein. During the 9th-15th week of embryonic fetal development, the large primitive axial vein drains the lower extremity. When the femoral vein grows in the thigh, this main axial vein transforms into a minor arch along the sciatic nerve venous plexus. The term sciatic vein refers only to the vein that was present in the embryological period. This plexus, if retrograde, allows the transmission of a reflux from the pelvis to the popliteal fossa and leg via gluteal veins. Welcome. The obturator vein is one of the origins of the hypogastric vein. One of its intropelvic branches can connect with the external iliac vein. It's born in the thigh from the union of a posterior branch from the head of the thigh bone and a muscular anterior branch. The anterior muscular circumflex branch joins the angle between the femoral vein and the saphenous arch. just immediately above or below the terminal valve. It's the obturator point. It enters the pelvis through the obturator canal. It's connected to the deep muscular circumflex vein, a venous arch between the inferior gluteal and deep femoral. Competent terminal valve of the great saphenous vein and varicose vein of pelvic origin. The anterior circumflex muscular vein runs in the perineum muscle, immediately below his fascia, represented by the red line. Superficial external pudendal artery clearly detectable above the perineum muscle fascia. The obturator point reflex is clearly detectable during the systole of the Valsalva maneuver. Different therapeutic strategies in obturator point reflex treatment depending on the hemodynamic conditions, the vein diameter and symptoms. Starting on the left, saphenous femoral and obturator point disconnection if there is the terminal valve incompetence. Obturator point and N2 and 3 disconnection or great saphenous vein high ligation section below the superior arch collaterals. Only multiple great saphenous vein high ligation disconnection below the superior arch collaterals in case of competent terminal valve but terminal valve incompetence and retrograde great saphenous vein. Welcome to the interconnected pelvic valvular venous plexuses spread blood flow in every direction. From the uterine vaginal plexus originate the uterine veins, which are valveless, and drain into the hypogastric veins. The uterine veins receive the round ligament veins. Welcome to the ultrasound. Round ligament vein flows into the uterine ovarian angle, joining the uterine veins. Is the intropelvic extension of the veins of the round ligament plexus contained in the inguinal canal, which drains the subcutaneous veins of the mount of Venus and perineum and inguinocrural area. It's a communication between the wall, lower limbs, and pelvic veins. The flow is normally directed towards the pelvis but can take the opposite direction during pregnancies and in pathological conditions. Welcome. Top left, an anatomical scheme. The continuous red line represents the abdominal oblique muscle fascia. The eye point is the superficial ring of the inguinal canal. The yellow line is the transversalis fascia. In the fat tissue, below the transversalis fascia on the right, the inferior epigastric vein, blue dashed line, and the inferior epigastric artery, orange dashed line, are detectable. Immediately below and laterally to the inferior epigastric vessels, the external iliac vein is detectable. Welcome to eye point disconnection scheme mark. Welcome. The oblique external muscle fascia, the superficial ring of the inguinal canal, and the round ligament plexus together with the genitocrural nerve are clearly detectable. The genitocrural nerve has been isolated and preserved, and the venous plexus prepared for ligation and sectioning. The disconnection is terminated. The white dashed line is the subcutaneous ring of the inguinal canal. The nerve coming out of the inguinal canal is clearly detectable. The white arrow highlights the polypropylene stitch necessary to fold up the deep stem of the venous plexus inside the inguinal canal. Welcome to the ultrasound. The pudendal veins are the most important drainage path of the pudendal plexus. They are fundamental in pelvic drainage. They have valves and drain into the hypogastric vein. They receive blood from the other plexuses and from the inferior hemorrhoidal vein, the perineal vein draining the vulva and labia majora, the deep dorsal vein of the clitoris and the penis. They are responsible in case of pathology for reflux through three distinct pelvic cliques: P point, intermediate P point, and C point. Reflux through the P point and intermediate P point is fed by retrograde flow in one or both the pudendal vein, passing through the perineal vein, a vein that crosses the deep perineum muscle, which forms the floor of the urogenital triangle, bottom right. The P point is the point where the posterior labial vein from the subcutaneous tissue, 1 cm anteriorly to the frenulum labra minora, enters the labia majora through the perineal fascia. In the top central photo, you can see a case of coexistence of the P point with the intermediate P point. In fact, also the intermediate P-point exists. Surgery of the P-point is performed with the patient in lithotomy position as shown in the left upper angle of the picture. The operating table is perfectly horizontal during surgery. In the lower left angle of the picture, reversed lithotomy position of the operating table for the mandatory intraoperative skin marking check. In the upper right angle of the picture, the beam-mode image of the labial vein and of the vulvar fascia. The fascia hole representing the P-point is clearly detectable. On the right inferior angle, the skin mark and the position of the P-point is detectable. The disconnection at the very fascia hole is necessary to avoid recurrences. Local anesthesia, small skin incision, it's a minimally invasive surgical procedure. Welcome to the ultrasound world. A reverse flow from the pampiniform plexus can reach the lower limbs feeding ipsilateral or contralateral varicose vein, passing through penis venous plexuses as well as the scrotal veins or anteriorly in the subcutaneous plexuses of the pubis. The pampiniform plexus consists of an anterior and a posterior group of veins with the deferent duct between them. The posterior group of veins drains into the superficial epigastric vein, while the anterior one drains directly into the great saphenous vein arch. For these reasons, there are different male eye points to consider. The male C point also exists. It's the subcutaneous fascia hole crossed by a venous collector connecting the penis path to the subcutaneous venous plexuses. The origin of the reflux can be the pudendal vein as well as the contralateral pampiniform plexus.